Today is October 19th, 2022, and we are here with Dr. Paul Offit. Dr. Offit is the director of the Vaccine Education Center and an attending physician in the Division of Infectious Diseases at the Children's Hospital of Philadelphia. He is the co-inventor of the RotaTeq vaccine for rotavirus. He's published over 130 papers in medical and scientific journals, and he is the author of many books on vaccines, antibiotics, medical overuse, and medical history, including You Bet Your Life, which was published in September of 2021. Paul, welcome back to the External Medicine Podcast.
My pleasure. Happy to be back.
All right. Any financial disclosures since we last spoke?
Nope. Not a one.
All right.
So let's start with chatting briefly about You Bet Your Life. In that book, you tell the story of a number of different medical innovations in the 20th century, by and large: heart transplants, blood transfusions, anesthesia, vaccines. And you focus a lot on people who were either the victims of this progress or were harmed in the process of either getting the science right or even after the science was right due to some mishap. Why did you write this book, and what did you learn while writing it?
I think the reason I wrote it was to make the point that no medical innovation in history has ever occurred without a human price to pay. In other words, that innovation requires a human price. And we never accept that. We always think, well, right now, I mean, science is so advanced, medicine is so advanced that we won't need to pay that price. But we will be paying it. We paid it right up to the present time. I think I was writing it around the time that that COVID was happening. I started before COVID and then was writing during COVID. And I think, I'm on the FDA Vaccine Advisory Committee, and it just struck me when we were, going through listening about the phase 1 trials, phase 2 trials. So when you would hear these sort of company CEOs say, look, we've done a phase 1 vaccine, we have great immune responses, now we can make tens of millions of doses. And you're thinking there is going to be a price to pay for this. There always is. There's always anything that causes a positive effect can cause a negative effect. There is not an innovation in history where that hasn't been true, and it was true. I think the price to pay was very small with regard to the mRNA vaccines and myocarditis. It was somewhat bigger with regard to the vectored virus vaccines of J&J and these clotting disorders, which including central venous sinus thrombosis and death. But people are always upset by that. Always. They always think, well, how did they not know this? How can they not know these things? And the point of the book was that we never have, and we never will. There will always be something you learn because that's the way it works. I think with the old Hector Berlioz's line, which is, time is a great teacher, but, kills all its students.
So of all the different stories that you told in that book, which one was your favorite to learn about and recount?
The Jesse Gelsinger story, because it was a gene therapy story, and it was at Penn, and it was at Children's Hospital of Philadelphia. So I lived that story. I mean, here you have, Jim Wilson, who was a star in the world of gene therapy, who did it the right way. I mean, he did experimental animal model studies initially in rodents, then non-human primates, and then slowly worked his way up. In this case of Jesse Gelsinger was a 19-year-old man who was lacking a certain liver enzyme called ornithine transcarbamylase, which meant that he wasn't able to sort of rid himself of ammonia, the ammonia that was the process of sort of protein metabolism. And so ammonia would build up in his bloodstream. He would faint or go into a coma, and unless he took a 32 pill regimen and really severely restricted his diet, which was really hard as a teenager to do that. So he volunteered for this trial. And what they gave him was essentially very similar to what's done for the J&J or AstraZeneca vaccines, which is a vectored virus, meaning a non-replicating adenovirus into which was inserted this gene that he lacked, which was then injected into his artery, so it would be taken up by his liver so that he could make the enzyme he didn't have. And they worked slowly in terms of like amount of virus that was given, one step at a time. In fact, a woman right before him received the same dose that he got. But when he got it, he was overwhelmed. And, within a couple of days, he was in the intensive care unit at the hospital at the University of Pennsylvania, dying of what looked like bacterial sepsis. What he had was one particular aspect of his immune system, production of interleukin-6, was in overdrive. But they didn't know that. And they didn't know that. The researchers didn't know that till afterwards. It wouldn't have mattered. Even if they knew that it was a massive production of this one particular cytokine called interleukin-6, there's nothing they would have been able to do about it. There wasn't a monoclonal antibody available. But then, sort of fast forward, more than a decade, and Emily Whitehead, a little girl who had acute lymphoblastic leukemia. She was treated unsuccessfully with chemotherapy. She was treated unsuccessfully with a bone marrow transplant. And then she too was given a type of gene therapy, so-called CAR T therapy, where you take out her cytotoxic T cells, re-engineer them so that they are directed to kill her leukemic cells, put those cells back into her chemo, that works to kill her leukemic cells, but she then has a reaction just like Jesse Gelsinger. So, the couple of physicians at Children's Hospital of Philadelphia said, isn't this very similar to what happened to Jesse Gelsinger? By that time, Jim Wilson had figured out what had happened to Jesse Gelsinger. And so they looked to see whether there was an excess production of interleukin-6. There was, massively so. Now you had a monoclonal antibody, tocilizumab, which was anti-IL-6. It wasn't obviously there for that reason. It was there for sort of rheumatoid arthritis and other things. But, they were able to get it from the pharmacy, give it to her, and save her life. And that has become now in many ways standard therapy for people who get CAR T therapy. Well, so what was interesting to me about that was that she was a hero. Emily Whitehead became a hero. She met President Obama. She was on Dateline NBC. She was feted. She was that major breakthrough for CAR T therapy. And if you go to Carl June's lab at the University of Pennsylvania, where all this CAR T therapy was done, all the original therapy, preclinical therapy was done, you see all these pictures of Emily Whitehead. What you don't see is a picture of Jesse Gelsinger. But without Jesse Gelsinger, you don't know what you needed to know when it happened to Emily Whitehead. So again, in many ways, Jesse Gelsinger, or the success of Emily Whitehead was because of Jesse Gelsinger. But we're much more comfortable sort of feting our successes than realizing or establishing the failures that inevitably lead to those successes.
So after finishing reading your book, you say at the very beginning, in the 20th century, US lifespan has increased 30 years. And some of this was due to medical innovations like the ones that you describe in the book. I guess the sort of takeaway question that I have is, what is your assessment as to whether the cost has been worth the societal gains?
Well, there's always a cost, and it works both ways. I think I'll give you an example. So this is relevant to SARS-CoV-2. When we, the FDA Vaccine Advisory Committee, had to vote on vaccines for children, say the 12 to 15-year-old, the 5 to 11-year-old, and when we voted for the 5 to 11-year-old, that was on a Tuesday. The 3 days before that meeting, we were bombarded with emails. I mean, I got 3,100 emails from people saying, vote no. That happened because there was a guy named Toby Rogers who had a Substack in which he then listed all of our names, all of our email addresses, and then got people to just massively write to us asking us to vote no, with the usual kind of, Hitler, Nazi, Satan, Holocaust analogies. But a few of the people asked a reasonable question. They said, I literally mean a few. I mean, like 3 of the 3,100 asked the question, really? Do you think you know enough? Do you think you know enough? So the studies for the 5 to 11-year-old, those were roughly 2,400 children. So 1,500 children got the vaccine, about 750 got placebo. And there were 16 cases of COVID in the placebo group, 3 in the vaccine group, for an efficacy of around 90%. So people say, 2,400 children, that's it. I mean, when Pfizer did its trial on adults, it was 40,000 adults. When Moderna, it was 30,000. Now you're going to be making a decision for children based on 2,400 children. To which you could respond, okay, we can do 24,000 children, aside from the fact that it will take longer before the vaccine is available. Now, instead of having 16 cases in the placebo group, you can have 160. How much suffering do you want to have here before you can say comfortably that you can move forward? And what that reminded me of, and I talk about it in the book, You Bet Your Life, was the polio vaccine, because I am old enough to remember the polio vaccine. I mean, I was a child of the 1950s, so I certainly remember my mother crying when the polio vaccine was finally out there in the mid 1950s. But look at the way that played out. The way that played out was Jonas Salk, right? Jonas Salk took polio virus, grew it up in cell culture, purified it, killed it with a chemical formaldehyde, tested it in 700 children in the Pittsburgh area, found that it was safe and that it induced an immune response that he believed would be protected. As far as he was concerned, we were done. Let's go. Let's mass produce it and get it out there. We don't need to do anything else. But that's not the way the National Foundation of Infantile Paralysis, the March of Dimes, felt. They thought we need to do a big clinical trial. He didn't want to do that trial. He could not conscience giving a placebo to children in the 1950s when you knew that every year there were 30,000 cases of paralysis, 1,500 deaths a year. He could not conscience that. Nonetheless, that's the way it was done. I mean, the March of Dimes was paying for all of this. They paid for the phase 3 trial. They paid for mass production. That actually was Operation Warp Speed 1. When people think that Operation Warp Speed was novel, that was Operation Warp Speed 1. Government, not the government, but this private philanthropic organization, the March of Dimes, paid for all of it. And so what did they do? They, and Thomas Francis, who was at the University of Michigan at the time, ran this trial. 420,000 children got vaccine. 200,000 got placebo, meaning injected with salt water. And as a nod to Jonas Salk, 1.2 million children served as observed uninoculated controls. That was a 1.8 million child study. I don't think any study has been done that big before since for any medical product. And so a year goes by and that study is finished and Thomas Francis gets up in front of the crowd at Rackham Hall, where packed with newsmen ready to see whether or not this vaccine worked. And he said those three famous words: safe, potent, effective. Those three words were on the headline of every major newspaper in this country. Church bells rang out, synagogues held special prayer meetings, department stores stopped. People stopped while the department store made the announcement over the loudspeaker. It was carried in Voice of America. So how did he know? How did Thomas Francis know that that vaccine was effective? He knew it was effective because 16 children died of polio in that study, all in the placebo group. He knew it was effective because 36 children were paralyzed in that study, 34 in the placebo group. I mean, those children were first and second graders in the 1950s. I was a first and second grader in the 1950s. They could have lived long, healthy, productive lives, but for the flip of a coin. So the price that you pay for knowledge works both ways, both in this sort of stumbling on the way to learning and the price that you pay to prove that something works. And it's, the motivation for me in the book was trying to get people to understand all that. I just don't think people do understand it. They think you just snap your fingers and there's your magic vaccine or your magic antibiotic or your magic anesthesia or your magic genes therapy or whatever, and it works perfectly and it's completely safe and there you go. And we're intolerant of that human price that is invariably paid for knowledge.
Are you saying that you think that trial to test Salk's vaccine was warranted, given that it was possible that the vaccine had a flaw and people could have died from receiving it? Or do you feel like Salk's intuition beforehand was right and we should have skipped that phase of skip the actual like RCT on it?
So there's two ways to look at it. One, do it the way we did Ebola, the Ebola vaccine. So you have an Ebola outbreak in West Africa. People are dying by the hundreds. You now have a vaccine, this vectored virus vaccine, very similar to J&J's vaccine, an adenovirus vaccine, into which you have cloned the gene that codes for the Ebola virus glycoprotein, the surface protein, and then just start to give it. And so you're not doing a placebo-controlled trial, but not everybody gets it at once. Some people are getting it, some people aren't getting it, and then you can, at least as you're moving along, get a sense of whether or not it's working or it's not working. But the Salk vaccine had a problem. I mean, it was, and that didn't become clear for a little while. It was on sort of in April 12th, 1955. That vaccine was then licensed over a period of 2.5 hours. It took 2.5 hours to license that vaccine. It takes a little longer to get a license for your vaccine today, a little more like 10 months to a year, but unless it's COVID. COVID obviously is an exception. And so when that vaccine rolled out on April 12th, 1955, 5 companies made it. One of them made it badly, Cutter Laboratories of Berkeley, California. I also talk about this in the book. They failed to fully inactivate the vaccine. As a consequence, 120,000 children were inoculated with live, fully virulent polio virus. 40,000 developed abortive polio, meaning this was primarily in the West and Southwest. 120,000 children in this country in 1955, in April of 1955, were inoculated with polio virus, with live, deadly polio virus. 40,000 developed abortive polio, meaning short-lived paralysis. 164 were permanently paralyzed for the rest of their life, and 10 were killed. I think it was the worst biological disaster in this country's history. We called it the Cutter incident, but that wasn't accurate. What it should have been called was the scale-up incident, because that's the hardest part of making vaccines is making vaccines. It's scaling them up. And Wyeth also had a problem. Wyeth also, I think the public really probably never knew about that. That was primarily a sort of an Eastern phenomenon, East Coast phenomenon. Wyeth also made a vaccine that paralyzed and killed children, although to a much lesser extent than Cutter. The other 3 companies that made a vaccine all had problems in activating the virus, but they figured it out. So if you did what you do with Ebola, and just start rolling it out, and you come up with that kind of problem, that also is a problem because you again lose trust. It's the stumbling, it's the fits and starts that are inevitable in this kind of learning process.
You bring up right there sort of the sin of commission, of giving a vaccine that turns out to be harmful. In your book, you write, quote, although federal guidelines lessen the chance of disasters, they will never eliminate them. Unanticipated tragedies are unpreventable, no matter how many regulations, training programs, fines, or penalties are put in place. So I'm curious, had researchers been more cautious developing some of these technologies, take the polio virus vaccine, and say it had delayed it by 5, 10, 20 years, there would likely have been thousands and thousands of more people who were either paralyzed or died from polio. 2 questions. The first is, should we treat the sin of commission and sins of omission the same when it comes to technological development? And second, how should we be thinking about risk? Should we be taking more risks in research in order for potential future gains, or should we be taking fewer risks?
Well, we're always taking risks, and we will always perceive the sin of commission as being worse than the sin of omission. We will. I mean, the rotavirus vaccine is a perfect example. The first rotavirus vaccine in this country, which was introduced in 1998, was found to be a rare cause of intestinal blockage called intussusception, where the intestine sort of telescopes into itself, gets stuck, and when that happens, you can get and the lining of the intestine can be damaged, which can cause massive hemorrhage, which can be fatal. The lining of the intestine can be damaged, which causes the ingress of bacteria that live at gram levels on mucosal surfaces, which can cause sepsis and also be fatal. So intussusception can be fatal. And so when that vaccine came out, it was found really in the first 10 months or so to be a rare cause of that intussusception. And so we took it off the market. And I was on actually the advisory committee for immunization practices at that time, and argued unsuccessfully that we shouldn't take it off the market. That if you just look in the United States, forget the developing world where, thousands of children were dying every day. I mean, about 2,000 children die a day from that virus back in the late 1990s before we had any vaccines. And even in the US, you would be 5 to 10 times more likely to die from the virus, which would kill maybe 60 children a year, than you would ever die from the vaccine. So let's get it out there. But, there was little appetite for that because people, just the reason you say, you perceive that differently. You perceive that risk differently. If it's because this is something I'm giving to my child, as compared to if I just stand back, my child may get rotavirus, may get seriously ill with rotavirus, may die from rotavirus, which happened in this country to 60 children every year. But that somehow is perceived differently. I don't know how you ever make that change. Where we perceive that differently. And you're right. I think we're terrible at perceiving risk. I don't think we understand risk. I mean, what's the biggest risk of vaccines? Driving to the office to get them. I mean, statistically, that's you're most likely to die. I don't think people see it that way. And look at, the New York State lottery, I think at one point was trying to sell a 14 million to one shot with a simple phrase. It happened to you.
So in 2017, you wrote an article for the Daily Beast on the topic of Rachel Carson and DDT. Who was Rachel Carson, and what did she get wrong about that insecticide?
Right. So Rachel Carson, by the way, I don't think I ever got more hate mail than I got from that particular article. So Rachel Carson was an environmentalist who believed that DDT, chemical that was used as a sort of a mosquiticide, to kill mosquitoes, was dangerous to the environment, would cause thinning of eggs, which could then result in sort of wiping out bird populations, as well as a variety of other mammalian and avian species. And so that was her premise. Her premise was that we should stop using this insecticide, or else we're going to be doing even more harm to the environment. It was an easy sell. All you have to do is mention the chemical name, and people, are against it. I remember there was Penn and Teller did this thing once, where they had a petition at a California fair. Maybe it was California, so maybe that doesn't count. But in any case, they had a petition at a California fair where they wanted to ban dihydroxymonoxide, right? So Teller, the little guy that doesn't talk. So he's on a blackboard and he writes dihydroxy, 2 hydrogen molecules, 1 oxygen, and so it's water, basically to ban water. And so you listen to this when they go around in California. They say, it's in our waters, it's in our streams, it's a consequence, it's in our tears, it's in our urine. This dihydroxymonoxide, we have to ban it. And thousands of people sign a petition to ban water from the face of the earth. Which you can do by just giving its chemical name. You have somebody, smart people like Meryl Streep, talks about how her father was a farmer in New Jersey, but he never used chemicals in his farming. Never. No chemicals, not salt. No, nothing. It's a little hard to believe. So and DuPont, used to sell, I don't know if you guys are too young, but one of their advertising taglines was better living through chemistry. That didn't last long. And that didn't last into the modern age. So that was it. She appealed to that notion. DDT sounds terrible. And that term became really synonymous with poison. The problem was when then the World Health Organization, which wanted to try and salvage some use of DDT because they knew that you didn't have much else to try and stop this, this terrible scourge, the biggest killer of people in the world, which is malaria, that they didn't want to ban DDT. But it ended up just they were overwhelmed by sort of the environmentalists that were standing behind this, and the incidence of malaria shot up dramatically, and people died because of it. So that's the other side of this. And that story just never got told, I thought, in a compelling enough fashion. So I told it and really dramatically increased my hate mail. I always thought the anti-vaccine activists were pretty virulent, but go with those environmentalists. It's a pretty tough crowd.
Some of the statistics there are crazy, and you go through a bunch of different countries, but one of them that was particularly striking was in India. Between 1952 and 1962, DDT caused a decrease in annual malaria cases from 100 million to 60,000. And of course, once DDT gets banned, then that number shoots way back up. But that's crazy that it cut malaria by that amount.
Right. It's and it's crazy that the numbers went back up again when DDT was removed.
What are your thoughts on the recently developing malaria vaccines?
Yeah, I think so. The so-called RTSS vaccine was about 30% effective. I think we need better malaria vaccine. The current vaccine is maybe 30 to 40% effective at preventing disease. We need a better vaccine. I know the mRNA technology is being applied to the malaria vaccine. We'll see. It's hard to make. I was fortunate enough to work with the team at Children's Hospital Philadelphia that created a rotavirus vaccine. Viruses are small. Like the rotavirus has 11 proteins that make up the virus. That's small. When you make a vaccine against a parasite, it's like trying to make a vaccine against an animal. There's just many, hundreds of proteins, and you're trying to figure out which are the ones that are critical. And it's really much, much harder. How many anti-parasitic vaccines do you have? Pretty much none.
So moving on to boosters. Before getting into some questions about the bivalent booster, I just wanted to clarify for myself some of the confusing agencies and organizations involved in actually overseeing vaccine development and approval. So you were previously on the advisory committee for immunization practices of the CDC, and you're currently on the FDA advisory committee. So what exactly are these committees, and what is their relationship with the FDA, CDC, and other organizations that approve or recommend the use of vaccines?
Right. So the FDA is a regulatory body. They have this so-called VRBPAC committee, which is Vaccine-Related Biological Product Advisory Committee, on which I sit. And so when vaccines are then put forward, like in December of 2020, when Pfizer's vaccine was put forward before us, or Moderna's vaccine was put forward before us, the way that works is you get about this is an era now where we're dealing with emergency use authorization. It's not licensure, at least not initially. I can tell you the difference in a second, but you get like an 80 to 100 page document from the company, which goes through all their data. In the case of, say, Pfizer, they're roughly 40,000 person trial, you get that document. Then you also get an 80 to 100 page document from the FDA, who reviews all the primary data to make sure there's no misrepresentations or omissions. So you'll get 200 pages to review. You usually get about a week before you meet. And then you go through all those documents and you formulate your questions, and then you meet for a day or two, and the company presents, and the CDC presents, and the World Health Organization presents, and you can ask questions of the company. And then at the end, we vote on whether or not we think that the company should have the right to distribute this vaccine. That's all the FDA does. They say you now have the right to distribute this vaccine for this particular age group. Then it goes to the CDC. And so the CDC is a recommending body. So you could, for example, say that the company has a right to distribute it, but the CDC could say, we don't think it's of any use for anybody, so we're not going to recommend it. That doesn't typically happen, but that could happen. So then it goes to the Advisory Committee for Immunization Practices, which also advises the CDC. And then, by the way, the FDA can choose to accept our recommendations or not. I mean, typically they accept the recommendation, but they don't have to. We can say no, and they can turn around and say, we want to do it anyway. The same thing with the Advisory Committee for Immunization Practices, the CDT. They go through the same process. Then they make a recommendation to the CDC, and then it's the vaccine is recommended or it isn't. That's the way that works.
So in September, you wrote an op-ed in the Wall Street Journal entitled "CDC Oversells the Bivalent COVID Booster."
Yeah, first of all, I'd like to point out that I don't write the titles. As you know, in the world of public publishing, in any journal, whether it's New York Times or Wall Street Journal or Washington Post, we don't write the titles, okay? They write that. So I didn't write that title. Okay, but go ahead.
What title would you have chosen if you could have written your own title?
No, I would say, if I got to write my title, I think I would have written "Boosters Aren't for Everyone," I think is what I would have said.
All right. Can you describe some of the data that you included in that op-ed and what your opinion on the current bivalent booster is?
Right. Okay. So we'll start from the beginning. When this bat coronavirus made its debut in the human population in October, November 2019 in Wuhan, China, that virus, which caused a few thousand people to die in China, that virus was isolated and sequenced in January of 2020. So about 3 months later, now you could make a vaccine, and so vaccines were made over an 11-month period to prevent that strain, that original strain, what's been called the ancestral strain or the Wuhan 1 strain. That's the strain to which all of us have been vaccinated to protect against, Wuhan 1. That's not the strain that left China. The strain that left China was the first variant. It was called D614G because it was more contagious. And that's the virus that swept across Asia, swept across Europe, swept across the United States, killed a couple 100,000 people, which was replaced by the Alpha variant because it was more contagious, which was replaced by the Delta variant because it was more contagious. And that takes you through the first year. From December of 2020 to December of 2021, those are the 3 variants that you were dealing with in the United States. So did the vaccine work? Did 2 doses of vaccine that were recommended back in December of 2020, did those 2 doses work to work? And by work, what I mean is prevent severe illness, because that's the only attainable strategy. That is the only reasonable strategy for this vaccine. Prevent severe illness. This is a short period mucosal infection. You are not going to prevent mild illness over time. You're not, even if you get 2 doses of vaccines, 2 boosters a year, you're not going to prevent mild disease. So, and rotaviruses are an example. I mean, our vaccine's been out since 2006, probably has 95% uptake among babies, and it basically has eliminated hospitalizations in this country, but that virus still circulates in the community, it still causes mild disease, and it doesn't mutate. So even if the whole world were vaccinated against COVID, even if the virus never mutated, it would still cause mild disease, and if you want, we can talk about why. But in any case, at the end of the first year, according to the CDC, according to their publication, Mark Tenford, clinical infectious disease. He tried to answer the question, are you still protected against severe disease 1 year after that vaccine came out? And the answer was yes. It was true for Pfizer's vaccine. It was true for Moderna's vaccine. It was true for people over 65. It was true for people with more than one comorbidity. That vaccine still protected you against severe disease. Then Omicron hit, and Omicron, at end of December, Omicron hits, and then the Omicron subvariants, which takes us to the current time. So then that was not only more contagious and not only have a shorter incubation period, it was immune evasive, meaning it was evasive for protection by neutralizing antibodies. It was evasive for protection against mild disease. So even if you've been vaccinated, even if you've been naturally infected, even if you've been both vaccinated and naturally infected, you can still get a mild illness or a severe illness, depending on who you were. So the CDC did studies, their studies that were done answering the question, were you less likely to have severe disease if you got a third dose? And the answer was yes. And then they did a study, were you also less likely to have severe disease if you got a fourth dose? And the answer was yes. But not everybody. These are their data. These are data they have published. The people who benefited from those booster doses fell into three groups. One, and most importantly, the elderly. And it wasn't just like the over 55, over 65. It's what Rochelle Walensky, God bless her, has referred to as the elderly. And that's good because I'm still younger than that. People over 75. And people who are immune compromised, and people who had the kind of comorbidities, serious health problems, like chronic lung disease, chronic heart disease, where even a mild illness could tip them over and cause them to go to the hospital. Those three groups benefited. Great. Target those three groups. There was just a paper that came out in the last 2 days out of that was looking at people, nearly 30 million people this was looking at, who either got boosted or got 2 doses of vaccine or 3 or 4 to answer the same question. And this was done in UK, Northern Ireland, Scotland, Wales, and found the exact same thing. The only difference was the elderly were over 80. So target those groups. The point of that op-ed piece was when on September 1st, the CDC said that everybody over 12 years of age should get a bivalent vaccine. Why? Why everybody? I mean, why not just focus on those groups who are most likely to benefit? Because this is true in all of medicine. Anything that has a positive effect can have a negative effect, which is something you're perfectly willing to accept as long as the benefits are clear. But if the benefits aren't clear, then it's not fair to ask people to take a risk, even if it's a rare risk or even mild risk. It's not fair to do that. So that's why I wrote that piece and got, a pushback from people who I still consider friends, even though they may not consider me their friend. That how can you do that? How can you basically criticize a public health policy? All you're doing is enabling the anti-vaccine people. You're just giving them fuel, but that's not the way science works. The way science works is that you're constantly questioning it, and you should be. You should always question the science on which policies are built. You shouldn't just blindly accept them. So that's why I wrote that piece.
And just to clarify, these studies, this study that you were just referring to in the data, this is for an initial booster dose, the third dose after the two, like Pfizer versus Moderna, 2 doses. That does not have benefit in people who are younger and healthier, or are you referring to the 4th dose?
I'm referring really to the 3rd dose. I still can reasonably argue that 2 doses for healthy young people prevent severe disease. I think the question that needs to be answered over time is for how long. And remember, severe disease is largely mediated by T cells, and T cells, unlike antibodies, are recognizing conformationally conserved epitopes on SARS-CoV-2 spike protein. I mean, there's 80% conservation between the epitopes recognized by T cells on Wuhan 1 to BA4, BA5. That's why, take me as an example. I had 3 doses. I work in a healthcare facility, and so got my 3rd dose in November of last year. And then in May of this year, I had a mild illness. So it was May. So assume I was infected with BA2. So I got 3 doses of vaccine to protect me against Wuhan 1, and I got a BA2 infection, which caused a 2-day mild illness. Why? Because I was still protected against severe disease. And the question is, for how long? And I think that the CDC needs to, epidemiologists at the CDC, in concert with immunologists and academia, need to answer that question: for how long are you protected against severe disease based on how many doses you've gotten, who you are, how old you are, what comorbidities you have. That's the data that you need to see moving forward. For how long am I protected against severe disease? I'm not planning on getting a booster this year because I think between 3 doses and a natural infection, I think I'll have a high level of hybrid immunity. I don't think I benefit from that. So that's why I'm not getting it.
Could you talk a little bit about the difference between a short incubation period virus and a long incubation period virus and what we can expect in terms of vaccinating against those?
Sure. So the incubation period is the time from when you're first exposed to the virus to when you develop symptoms. If you assume that antibodies are critical at preventing mild illness, and they are, you need sort of high levels of neutralizing antibodies at the time of exposure to prevent mild disease, because mild disease happens quickly. Take Omicron. The Omicron incubation period is estimated to be about 3.2 days. So that's fast. So you need antibodies at the time that you're exposed if you're going to protect yourself. For long incubation period diseases, where it takes, let's say, measles, where it could take 2 weeks to develop a mild illness, there all you need is memory, because immunological memory cells have plenty of time to become activated and differentiate, to become effector cells and protect you against even mild disease, which is why you can eliminate those diseases. You can eliminate measles, and we did. We eliminated measles from this country by the year 2000. It's come back in large part because a critical percentage of parents have chosen not to vaccinate their children. You can rubella. German measles, another long incubation period disease. We eliminated that virus by the year 2005. Smallpox has been eliminated from the face of the earth. I mean, since the 1970s. And polio, at least the paralytic part of polio, is relatively long incubation. So you can eliminate polio, as we did from this country, by 1979, and from the Western Hemisphere by 1994. So, you can eliminate those. You'll never eliminate this virus. I mean, maybe it'll peter out because it's hard to figure out what this virus is going to do, but I think it's probably going to be with us for decades. And even if the whole world were vaccinated, this virus would still circulate because it's a short incubation period. And we haven't explained that well. And I think the moment when that happened, and I lay this at the lap of the CDC. I think in July of 2021, in July of last year, there was a big celebration in Provincetown, Massachusetts. So thousands of men get together celebrating the July 4th holiday. 79% are vaccinated. Nonetheless, among those who are vaccinated, 346 developed COVID. 4 are hospitalized. 4 of those 346. That's a 1.2% hospitalization rate. That's a win. That is great. That is a vaccine doing great. The other 342 developed either mild infection or asymptomatic infection, which the CDC, in their publication in Morbidity and Mortality Weekly Report, you can go back and look at that, use the term breakthrough. Breakthrough implies failure. This was not a failure. This was a moment to celebrate that vaccine, to say, look, these people who got this vaccine, who got 2 doses of this vaccine, when exposed to the virus, still only developed a mild or asymptomatic infection. This vaccine is doing exactly what you want it to do, but we didn't do that. We used the terms like breakthrough, waning immunity. A month later, President Biden gets up in front of the United States population and says, as of the week of September 20th, we are going to offer an additional dose of vaccine for everybody over 16, because he thus shifted the goals. I mean, the goalposts, we now had mission creep. The goal initially should have been protection against severe disease, but what he's telling you essentially was, we need to try and prevent all symptomatic infection or asymptomatic infection. Good luck. Good luck. That's not going to happen. So don't set that as a goal. And I think we've been struggling with trying to get the public to understand that ever since.
One thing that's been very interesting to me is a lot of the publications coming out focus in on antibodies and the quantities of antibody titers. I'm curious. So after the natural infection or vaccine, your adaptive immunity is primed to the pathogen. Could you walk us through exactly what happens with reinfection by that pathogen in terms of like how the B and T cells of the adaptive immune response actually work sequentially?
Right. So when you're initially infected or vaccinated, you develop high titers of hopefully you develop neutralizing antibodies, which will prevent the virus cell binding. And then over time, those neutralizing antibodies, usually 4 to 6 months, will start to fade. And that's been shown over and over again with this virus. But you still have immunological memory. The memory, however, the good news about COVID is that it takes a while to develop severe illness. So as long as you have immunological memory, and it takes a couple of weeks to develop severe illness, so there's plenty of time then for activation and differentiation of those memory cells, those memory B cells that make antibodies, those memory T helper cells that help B cells make antibodies, and most importantly, and this is not given nearly the attention it should be, memory cytotoxic T cells. These are cells that kill virus-infected cells after the infection has already occurred. And it's been shown in experimental animal models like non-human primates that those are critical cells in protecting against severe disease. The good news is they're usually long-lasting, and the good news is they recognize sort of conserved epitopes on the virus. So that's what's good about this. If it ever comes to be that a virus is generated, and it could happen, I mean, it happens with flu periodically, where you get a pandemic potential virus for which the population in the world has a blank slate. There is no population immunity. That's not true here, not yet. There hasn't been a virus that's come up where even if you've been naturally infected or vaccinated, you still are at high risk of severe disease, assuming you're otherwise healthy and young. That hasn't happened yet, but it might, in which case then you're starting all over again. So those memory cells generally are long-lived and recognize, more, certainly for the T cells, more conserved regions on the virus. And so if you ask me what kind of vaccine I would like to have a vaccine that also includes mRNA against the nucleoprotein, because the SARS-CoV-2 is a small virus that has 4 proteins. One of them is the nucleoprotein. That's a major recognition site for cytotoxic T cells. There was just a study published, actually, done in Syrian hamsters, where they showed that you got very broad immunity with that kind of vaccine. And so I would have volunteered for that study, but I wasn't a Syrian hamster, so I couldn't.
So you voted against the recommendation for the 4th booster shot because you thought that the risks outweighed the benefits. Most of the other people on the committee disagreed with you. I'm curious, what do you see as the downside of getting that 4th booster shot? What are the risks for someone who is not in the elderly, not in one of those other groups who's at risk, but is considering getting the shot? Why do you think that the risks outweigh the benefits for that?
Okay, so just to be clear, I did not vote against booster dosing. I didn't. I'm all for booster dosing for high-risk groups. That wasn't the question we were asked. We were asked to approve the use of a bivalent vaccine as a booster. That's what I voted against. I didn't think there was any evidence, and still do not think there's any evidence that bivalent vaccine was any better than what we had, which was the monovalent vaccine. And so the studies were done the right way. I mean, the 2 companies did the studies the right way. What they did was they looked at people who'd gotten 3 doses of the ancestral strain and then got a boost with the ancestral strain, or got 3 doses of the ancestral strain and then got a boost with the bivalent vaccine. Now, the data we were looking at was not the current vaccine. It was not BA4, BA5, it was BA1, original Omicron. And what they found was that they had about a 1.5-fold increase in neutralizing antibodies against BA1 if you got that bivalent vaccine than if you got the monovalent vaccine. That is not likely to be a clinically significant difference. It certainly hasn't been. Starting back from December of 2020, Moderna had a 2-fold increase in neutralizing antibodies as compared to Moderna. That did not translate to better protection against serious illness. So I didn't think that made sense. Similarly, I was worried that when you looked at sort of Pfizer's data, if they looked just at a monovalent BA1 containing vaccine, which they did, you had a much better neutralizing antibody response than if you gave it as a bivalent vaccine, because we're all primed against Wuhan 1. So if you give those 2 together and then it gets taken up by the local lymph node into the germinal center, you already have a germinal center primed for the ancestral strain. So it's much harder for that BA1 vaccine to then thrive, and that's why the neutralizing antibodies were lower. So you could actually make a case for giving the monovalent vaccine as a BA4, BA5 only. And then there were clinical data that were just published in the New England Journal of Medicine, which got no attention from the media, none, 0. Although I did point it out in my Wall Street Journal piece, was that there were clinical data. So there were, in that study that I just mentioned, where you either boosted with monovalent or boosted with bivalent, there were 16 cases of SARS-CoV-2. 11 were in the bivalent group and 5 were in the monovalent group. There were 6 cases of, by CDC criteria, clinically significant illness, 5 in the bivalent group, 1 in the monovalent group. You were better off getting the monovalent vaccine. And the reason you could argue for that was, let's say Moderna, take Moderna as an example. If you get a monovalent Moderna vaccine as an adult, you get 50 micrograms of mRNA. If you get a bivalent vaccine, you get 25 micrograms of the ancestral strain and then 25 micrograms now of BA4, BA5, but we only saw those data as BA1. Well, so the assumption is that, well, 25 plus 25 equals 50, which, while true from the standpoint of arithmetic, I don't think is true from the standpoint of biology, because what you're really doing is you're giving 2 separate vaccines at a child booster dose level. And that's why I think those results were so disappointing. Still, you don't see data. I mean, I thought for sure by now, by the end of October, we would see data clearly that this bivalent boost was much better than a monovalent boost. And all you see is press releases from these companies saying it's much better. Trust us, because they don't show us the data. And it just, that's what I was never against booster dosing. I think booster dosing is of value for certain groups. I just don't understand why we abandoned the monovalent vaccine. Because until we show evidence that this bivalent is better, because it is a new product and it should be treated, this is hence You Bet Your Life, with, with the humility of a new product. We've never given a bivalent mRNA vaccine in our history. We don't know about this vaccine. We will learn more about it when it's in millions of people. But at the very least, we should have clear evidence that from at least an immunogenicity standpoint, much less an efficacy standpoint, that it's better. And right now, we don't have any such evidence. If anything, the evidence is on the other side, that monovalent may have been better. So why then did the FDA choose to withdraw its EUA for the monovalent vaccine? It's just really frustrating to me.
Could you explain the competition at the germinal centers and how that could account for the bivalent booster of the 25 plus 25 micrograms being worse than just the 50 micrograms of the monovalent original booster?
Right, so you have a germinal center at the local lymph node that is now primed to respond to the Wuhan 1 mRNA, the SARS-CoV-2 spike protein. It's primed to do that. You've got all these committed memory B cells to that. So when you're giving now this other vaccine at the same time, remember that those committed B cells are going to drive that response much more so than trying to induce naive cells to become essentially antibody screening cells and later memory cells. It does happen. You can do that. You can then induce that germinal center to make antibodies that are novel, that are recognizing BA4, BA5, but are not recognizing the ancestral strain. You can do that, but it's a much higher climb to do that.
When I hear the critics of boosters for everyone talk about the new bivalent booster, some of the things that they bring up are troponemia in young males and immune imprinting. What are your thoughts on those 2 issues?
Right. So the when we looked at data, for example, back in 2020, not enough people were vaccinated at that time, tens of thousands, to pick up this what appeared to be what we now know as myocarditis. There have been studies that have been, and so now we know, for the 16 to 29-year-old, according to data from the Vaccine Safety Data Link and the Vaccine Adverse Events Reporting System, that anywhere from sort of 1 to 6,700 to 1 in 20,000, depending on the age and the gender, can develop a clinical myocarditis, meaning, chest pain, rapid heartbeat, as well as spillage into the blood of enzymes that are specific to heart muscle cells like troponin, creatine kinase. Creatine kinase is not specific to heart muscle cells, it's specific to muscle cells. But and then the more recent study out of Thailand looked at Pfizer's vaccine given in 2 doses. And right before the second dose, this study was done in 301 children between 13 and 18 years of age. And they looked at time 0 and then 3, 7, and 14 days later to again look at spillage of troponin and creatine kinase, and found that it happened in 2.5% of those children. So 1 in 45, not so rare. In addition, you now know that if you look, say, 3 months later, 6 months later at gadolinium enhanced MRIs, meaning heart specific MRIs, magnetic resonance imaging studies, that you still see some evidence of inflammation there now 3 months later, 6 months later. So there's always a spectrum of illness. And I think, although it seems to be a short-lived, self-resolving phenomenon, transient phenomenon, I'm sure there'll be a spectrum of illness with this, which is only to say that I would not give a vaccine to a healthy 12-year-old now. Who's already vaccinated. I mean, and I'm not talking about you should be vaccinated. And recently, I think just today or yesterday, the CDC the ACIP voted on adding COVID vaccines to the routine childhood immunization schedule. Good idea. I mean, every year, 3.5 to 4 million children are born who are completely susceptible to this virus. They should be vaccinated. I'm only talking about booster dosing. And is it true that booster doses can also do this, can do this sort of immune reaction against your own heart? Yes. So we'll learn about this more over time. I give credit to the American public in some ways, because this latest booster dose has not been taken up roundly. It's been taken up largely, I think, by those groups who know they need it. It's primarily people who are older, people who are immune compromised, people who have high-risk medical conditions. I think that those are the ones who really have gotten boosted. I think there are certain people who are healthy and young that are just they'll get 10 doses. But I think for the most part, it's been people who know they do need it at some level.
And what about immune imprinting?
Yeah, so I think you do lock in to some extent, but not completely. If you look at there was a study by Linda Safe published in New England Journal of Medicine, end of June. What she did was she looked at healthcare workers who received 2 doses of mRNA vaccines and then got a 3rd dose of vaccine. And what you found was with that 3rd dose, you did get an increase in neutralizing antibodies against BA4, BA5, which tells you that although I think there is imprinting, otherwise known as original antigenics, and it's not complete, you still can get some immune response, neutralizing antibody response against these novel epitopes on that next dose, because there's a broadening of the immune response just with giving the Wuhan strain. That's why you have to do those studies and compare it to the bivalent vaccine, which was done and didn't show anything terribly convincing. Those were not convincing data. I'm really looking forward to seeing data that shows that I was wrong. I mean, that the bivalent vaccines are clearly better, because right now, the only place you're hearing that from is the companies telling you that it's really better. So,
should a young male, let's say between the ages of 15 and 30, should they, if they've been infected with COVID, would you consider that equivalent to getting like 1 dose of a vaccine? Or would you say that they still should be vaccinated in the normal manner?
Right. So those studies are somewhat all over the place. You can find a number of studies showing that you're better off being naturally infected than vaccinated, for the obvious reason, which is that when the virus is reproducing itself, you'll generate far more in the way of viral proteins than you would necessarily if you just got the mRNA vaccine. But more importantly, you're making an immune response to all 4 proteins, including the nuclear protein. So that could, in the long run, serve you better. But it looks like for an asymptomatic infection, that drive may not be as great. And you know that I guess when you're getting the mRNA vaccines, you're getting a known dose of that viral protein, whereas when you're naturally infected, it's more variable. But do I think natural infection protects against severe disease associated with reinfection? Yes, I think that's true for many viruses, and this one too. This came up, by the way, when mandates started. When mandates started, there was actually a meeting by federal officials to answer the question: should we count natural infection as being vaccinated, essentially? And I was one of 4 people who was sort of asked that question, and I voted yes. I thought we should, but I think it really became a bureaucratic thing more than anything else. How do you prove you've been naturally infected? You can show that card here. See, my PCR is positive, which you can probably buy off the internet.
Now for a few rapid fire questions. Number 1, what is one important scientific article that you believe more physicians should be familiar with?
I think that most recent paper by Moderna in the October 6th New England Journal of Medicine. Look at that study. Look at that study in terms of the efficacy of this bivalent vaccine, clinical data for that, because those data weren't presented to the FDA and they weren't presented to the ACIP, but they are available, and you should take a look at them, because it does worry me when you hear public health officials say this is going to be great. And certainly theoretically it makes sense. You wouldn't be able to have the best immune response against the circulating strains. I mean, we're all vaccinated to protect against a strain that really never left China. Shouldn't we get vaccines to protect against the current strains, BA4, BA5, and like influenza, try and taper our strategy to that? Sure, it makes theoretical sense, but you should have clear evidence that it does make sense, that it did work. I mean, just theoretical shouldn't be good enough.
You have unlimited funds and you get to investigate one thing with an RCT. What do you investigate?
I want to look at the capacity of an mRNA vaccine that is directed against nuclear protein to induce protection against all these circulating strains, and for how long.
What important medical truth do very few of your colleagues agree with you on?
I think I wrote a book called Overkill, the subtitle of which, When Modern Medicine Goes Too Far, talking about, take a closer look at stenting. I mean, makes sense, right? I mean, you have angina, it's in one particular area. You have some evidence of heart muscle damage in that area. When you do a catheterization, you see that there's a narrowing of that vessel. Wouldn't it make sense then to open up that vessel with a stent? Yes. The problem is, and this was a study done in the UK, and how they ever managed to get this through an institutional review board is amazing to me, but they actually had placebo stenting, meaning you were put under, you underwent a procedure where you thought you were stented, and then you were asked about your chest pain from then on. And there was no difference. And the reason is it's not just that one big artery. It's also the small tributary arteries that follow that, which also are blocked. And you're not doing anything about that when you stent. So nonetheless, it's an industry. You can make the same case for colonoscopy with that recent study that just came out of, I think, Norway, showing very little pickup in terms of either preventing colon cancer or prolonging your life. The same thing's true with, with this whole PSAs and prostate biopsies, and that too doesn't seem to protect your life. I mean, I think there are certainly things that work. I certainly think that Pap smears were of value, but it's like it's the barnyard analogy, the Gilbert Welch barnyard analogy, right? You have a barn. You open the door. There's three animals in the barn, right? There's the rabbit, the turtle, and the bird. Okay, so the bird immediately flies out. To me, it's Gilbert Welch. That's the cancer that you are going to die from no matter what you do. So there's no advantage to diagnosing it early. Then there's the turtle, who is so slow that it doesn't matter how long you keep that door open. And that's the cancer you're going to die with and not from. And if you look at, prostate biopsies of men who were 75 or 80 and died for another reason, many of them have cancer that they died with and not from. And then there's the rabbit, where if you close the door quickly enough, you really can prevent, the dying from that, and that's the cancer that's worth trying to prevent with these kind of preventive things we do. But we tend to be really gung ho on them. For some of them, there's data, but for some there's data that it doesn't work. I just saw my doctor recently, and he's certainly gung ho, and I'm a little less gung ho, so I'm clearly getting on his nerves. But what can you do?
Paul, thank you so much for joining us on the External Medicine podcast. For people that are interested in learning more about you, can you give them any place you would like them to go on the internet or Twitter handle, something like that?
Yes, my wife knows all about that. I think I do have a website. It's like paul-offit.com or something. But then I do have a Twitter handle, which is at Dr. Paul Offit, but I virtually never tweet, and I never even look at my website. But my wife updates it whenever I write a book. She always updates it because she gets that stuff. I'm not a man for my time, I guess is what I'm saying.
Well, thank you once again. We really appreciate having you on.
All right.
Yeah, thank you so much. Have a great game.
Enjoy the game.
And we'll talk to you. All right. We'll talk to you soon. Bye-bye.
Take care. If you would like to support us, please consider subscribing wherever you get your podcasts, leaving a review, preferably a phenomenal review, or donate at externalmedicinepodcast.com/donate.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. This is not professional medical advice. A doctor-patient relationship is not formed. This concludes another exciting episode of the External Medicine Podcast.